Hey, future nurses! If you're getting ready for your peds exam and need to nail down GI disorders, you are in the perfect spot. In this study guide, we're going to break down all the must-know structural and inflammatory GI issues to get you ready for your exams and for the floor. Let's do this!
So here's our game plan. We'll kick things off with a quick overview to get our bearings. Then we'll work our way down the GI tract, covering the upper and then the lower structural problems. After that, we'll jump into the big inflammatory conditions. And to wrap it all up, we'll put your knowledge to the test with some NCLEX-style questions and a real-world case scenario.
All right, first things first, let's make this simple. When you think about pediatric GI issues, they really fall into two main buckets. And if you can get this basic difference down, everything else we talk about is going to make so much more sense.
Okay, so on one hand, you've got your structural disorders. I want you to think of these as, well, plumbing problems. These are physical defects, a part isn't formed right, or there's a blockage. They're often congenital, meaning the baby is born with it. On the other hand, you have inflammatory disorders. Here, the plumbing is built right, but the issue is the body's own inflammatory response causing chaos. It's a simple framework, but trust me, it's going to help keep all these conditions straight in your head.
All right, let's start our journey at the very top. We're going to dive into some of the most common upper GI structural issues you'll see in pediatrics.
First up is cleft lip and cleft palate. The key phrase here is incomplete fusion. Just picture it. During development in the womb, the different parts of the face and mouth are supposed to grow toward the middle and fuse together perfectly. When that process gets interrupted for whatever reason, you get these openings. It can be just the lip, just the palate, or both.
So when you're assessing a newborn, these are the risk factors you're thinking about. And notice folate deficiency is on that list. That's a perfect real-world tie-in to why prenatal vitamins are so important. Physically, a cleft lip is pretty obvious, but a cleft palate, that can be hidden. And that's why a careful assessment, taking a gloved finger and gently feeling the roof of the mouth, is an absolutely critical nursing skill.
This table is golden because it shows the huge shift in our nursing care. Before surgery, it's all about one thing: getting nutrition in safely. We're positioning them upright, using special bottles, burping them all the time. But bam! After surgery, our priority completely flips. Now it's all about protecting that delicate repair. That means no nipples, no pacifiers. We're positioning them carefully on their sides so secretions can drain. And we're using elbow restraints to keep their little hands away from their mouth.
Next up, GERD. Now look, almost every single baby has some gastroesophageal reflux, or GERD. That's just spitting up. It's normal. It becomes GERD, the disease, when that spit up is so constant and so acidic that it actually starts to damage the esophagus. That causes pain, makes them not want to eat, and can even cause breathing problems. Think of it this way: GERD is a laundry problem, GERD is a medical problem. So for us as nurses, our game plan really scales up depending on how serious this is. For basic GERD, we start with the simple stuff: smaller, more frequent meals, thickening the formula with a little rice cereal to weigh it down, and keeping the baby upright after they eat. But if it's diagnosed as GERD, we do all of that, plus we add in medications like PPIs to cut down on the acid. And for the really severe cases, that's when surgery, like a Nissen fundoplication, comes into play.
Okay, we've covered the top half. Now let's travel down the GI tract and look at some of the classic blockages and movement issues you'll find in the lower GI system of kids.
Our first stop is hypertrophic pyloric stenosis. Let's break that name down because it tells you everything you need to know. Hypertrophic means overgrown. The pylorus is that muscular little valve at the exit of the stomach. So what you have is an overgrown exit valve muscle that's blocking food from leaving the stomach. It's a one-way street that suddenly slams shut, and it almost always shows up in the first few weeks of life. The signs and symptoms here are so classic. The vomiting isn't just spit up, we're talking projectile, sometimes shooting clear across the room. And think about it, because the food never gets past the stomach to mix with bile from the intestine, the vomit is non-bilious. It's just formula. And these poor babies are literally starving even though they're eating, so they are always hungry. You might even see a little wave move across their belly as their stomach muscles work overtime trying to push food through that blockage.
Okay, NCLEX alert. If there's one thing you remember from this section, make it this. That palpable olive-shaped mass in the right upper quadrant is the absolute hallmark sign of pyloric stenosis. That's the overgrown muscle you're feeling. If you see this in a test question, you found your answer. Lock it in.
Next on our list is Hirschsprung's disease. The magic word here is aganglionic. It just means that a section of the colon is missing the special nerve cells, the ganglion cells, that tell the muscles to squeeze and push stool along. Without those signals, that part of the bowel just sits there, paralyzed. It can't move, and it creates a massive traffic jam of stool behind it. How this looks really depends on how old the child is. In a brand new baby, the #1 red flag is that they fail to pass their first stool, that meconium, within the first day or two. In an infant, you'll see a failure to thrive and just awful constipation. And in an older child, any stool that does manage to squeeze past that dead section is often described as very foul-smelling and ribbon-like.
Our third major lower GI problem is intussusception. The best way to picture this is like an old-school telescope folding into itself. One piece of the intestine literally slides into the part right next to it. Now, this causes a blockage, sure, but the really dangerous part is that it squeezes the blood vessels in the bowel wall, cutting off the blood supply. And that leads to swelling, ischemia, and eventually, the tissue can die.
And here it is, our next huge NCLEX memory anchor. If you see the phrase red currant jelly stool, your brain should immediately scream Intussusception. So why does it look like that? Well, that telescoping action causes inflammation, which leads to bleeding and a ton of mucus production in the gut. All of that mixes together with the stool to create this very unique classic sign.
So the whole clinical picture looks like this: sudden, severe, episodic belly pain. The child will be fine 1 minute and then suddenly start screaming and pulling their knees up to their chest. Then, 15 minutes later, they might be totally fine again until the next wave hits. On your physical exam, you might also feel a sausage-shaped mass in their abdomen. It's a very clear presentation that tells you this is a medical emergency.
Okay, we've nailed the plumbing problems. Now let's switch gears and focus on the inflammatory disorders, where the GI system is really under attack from inflammation itself. And of course, we're going to start with the most famous one, appendicitis. This is pretty straightforward. It's just inflammation of the appendix. It usually happens because the opening gets blocked by something like a hard piece of stool. And you'll see this most often in school-aged kids, with the average age being about 10 years old.
The way the pain progresses in appendicitis tells a critical story that you need to know. It starts out as this kind of vague, dull pain around the belly button. Then, over a few hours, it moves and gets very sharp and localized in the right lower quadrant. Now, listen up, because this next part is vital. If that child suddenly says, "Hey, I feel all better, the pain's gone," that is a huge red flag. That sudden relief often means the appendix has ruptured, releasing all that pressure. And shortly after, the pain comes roaring back, but now it's everywhere and it's severe. That's the start of peritonitis.
Our other big inflammatory disorder is Meckel's diverticulum. This one is another leftover from development in the womb. There's a duct that's supposed to totally disappear before birth, but sometimes it doesn't. And it leaves this little outpouching, or diverticulum, in the small intestine. The key finding to remember here is typically painless rectal bleeding. The child might have some belly pain too, but the fact that the bleeding itself often doesn't hurt is a major clue that points you toward Meckel's. The stools will look bloody, maybe with some mucus. This is something that has to be treated to prevent really serious complications like major bleeding or a bowel obstruction. Okay, deep breath. We've gone through a ton of info. Now, let's make it real. Let's see how all of this actually shows up on your exams and how you'll use it on the hospital floor. All right, time to put your knowledge to the test. You're the nurse. You have an infant who is fresh out of surgery for a cleft lip and palate repair. Look at these options. What is your priority nursing action right now? Take a second, really think it through. The correct answer is B. Right after this surgery, your two biggest goals are to prevent aspiration and protect that brand new suture line. By placing the infant's sideline, you're using gravity to help any blood or mucus drain out of the mouth instead of down their throat. Now look at the others. A, C, and D all involve putting something in the mouth, and any of those things could tear the stitches and ruin the surgical repair. Okay, let's try one of everyone's favorites, the select all that apply. You know these are tricky because they test if you can pull together all the correct interventions. So a parent has an infant with GERD. What teaching points are you, the nurse, going to make sure you include? The correct answers here are A, B, and D. Small, frequent feedings mean less volume in the stomach to come back up. Thickening the formula makes it heavier and harder to reflux. And keeping them upright uses gravity to your advantage. Now pay close attention to C and E. Those are great interventions for a baby with a cleft palate. And this is a classic NCLEX trick, right? They give you correct nursing actions, but for the wrong patient. You have to know the difference. Okay, this slide right here, screenshot it, print it out, put it on your wall. This is your cheat sheet for telling these three lower GI obstructions apart. It puts their key features right next to each other. Pyloric stenosis, that olive mass, and non-bilious vomit. Hirschsprungs,
ribbon-like stool, and no meconium in a newborn. Intussusception, red currant jelly stool, and that sausage-shaped mass. If you can master this chart, you are going to be in great shape for your exams.
All right, to wrap things up, we're going to put you right in the middle of the action with a final case scenario. This is where you connect all the pieces and really flex that clinical judgment.
So here's the setup. You're caring for a 10-year-old kid. They're 12 hours out from an open appendectomy, and listen to this key word. It was for a perforated appendix. That means it already burst, so the risk for widespread infection is super high. The child has an NG tube in and a surgical drain.
All of a sudden, you notice the child's temperature is climbing, their belly is getting hard and rigid, and their pain is getting worse and spreading everywhere. Based on everything we've talked about, what major complication do you think is happening, and what is your immediate priority as the nurse? What do you need to assess? What do you need to do? And who are you calling stat? That's your challenge. Thanks so much for joining me for this study session, and good luck out there.